Hi, Dr. Robert here today, and I want to talk about bio-unavailable calcium. This is really an issue that we have to look at it because bio-unavailable calcium is actually the #1 killer in the Western world. This is a big issue. So when I look at the hair tissue mineral patterns, I see this excessive calcium, and when we have calcium above 80, so on this test, we have a patient of mine whose calcium is at 100. So when that calcium goes above 80, that's when we start to run into bio-unavailable calcium. Now, the reason this is such a biggie because we have to understand what is bio-unavailable calcium. That's actually kind of a double-edged sword. It causes a calcium deficiency and causes bio-unavailable calcium, which is another disease that we call our deposition aging diseases. So in the young, we see a lot of calcium deficiencies that can lead to weak bones and deformities and scoliosis, pigeon toes, knock knees, bad posture, curvatures, bad teeth, and all that stuff. That's the calcium deficiency we see more in the young population. In the older population, we're seeing a calcium deficiency, but this bio-unavailable calcium, even though it's spilling into the hair tissue, it's showing up as all the aging diseases. So it's the hardening aging diseases, because when calcium should be in the bones, or it should be, most of the calcium is in the bones, but that 1% is used for muscle contractions, used for nerve transmission. So calcium is a major player. Now, what happens is when the calcium precipitates out of the solution, it precipitates out of the blood, then it deposits everywhere where we don't want it to deposit. So it's not depositing in the bones where we want it to be, it's depositing what we call our arthritic conditions into our joints. That calcium hydroxyapatite now becomes the degenerative joint diseases that are plaguing our culture. That calcium deposits are going into our arteries, causing all our hardening arterial sclerosis disease, the heart attacks, and all the cardiovascular diseases. This is a biggie. Also, we have the calcium plaquing in our brain, all our dementias, senilities, and Alzheimer's, Parkinson's type of brain disorders. We have the calcium in the eyes, the cataracts, the calcium deposits. You know, when calcium binds to an oxalate, that's your kidney stone. So we see this calcium in the younger population. This is calcium, this calcium deposition kind of gets us all in the end, but what we're seeing is it's showing its face way too early. We're seeing it in the 20s and the 30s and the 40s, when we really shouldn't be seeing this deposition disease until the 60s, 70s, 80s, and it's really doing a number. This is why it is really the #1 cause of death. So when the bones become weak and brittle, the elders will fall and they'll crack their hip, and then they're in the hospital doing a surgery, and that's usually what's killing them. So this bio-unavailable calcium is such a huge player. Now, why does it precipitate out of solution? This is where sodium and potassium and magnesium keep calcium in solution. So when sodium and potassium start to tank, then that calcium will precipitate out of solution and deposit where we don't want it going. So this is why we have this premature aging, Saturn type of diseases going on, and we have to address this. So this test is really putting a picture on how we're really aging at such a rapid rate. And so when we see this pattern where the calcium is high and the magnesium it's above, calcium should be at 40, this patient's at 100, magnesium should be at 6, it's at 10, but it's this ratio. So when that ratio, that calcium-magnesium ratio should be at about a 7-to-1 ratio, we're at a 10, so right there that tells me we got a blood sugar problem. because the calcium-magnesium ratio is truly a blood sugar ratio. Now, the calcium-potassium ratio is should be at a 4-to-1 ratio. In this ratio, we see it's at 33. We take the calcium, 100, we divide it by the potassium, which is very low, 3, and that gives us a 33 ratio, which is way too high, and that's just indicative of a very, very sluggish thyroid at a cellular level, meaning that the gland is making the thyroid hormone, but the thyroid hormone on a cellular level isn't getting into the cell because of the decreased cell permeability. And that potassium, sodium, that's what we call the charge, that causes the charge on the cell. So the sodium would be more the Venus feminine, that's the girls, where the potassium inside the cell, that's the boys. So when the boys are coming to the girls, that creates that electrical charge. That electrical charge allows the cells to become permeable. When the cell is permeable, the oxygen, the glucose, the nutrients, vitamins, minerals, all get into the cell, and the waste materials, the biochemical waste products, can leave the cell. When that cell permeability starts to diminish, then we start to run into many, many problems in life. And so it's a predisposing factor to all of our chronic diseases. And so we look at all these ratios, and here we see the sodium-magnesium ratio. We call that the adrenal ratio. And this is basically showing that our adrenals are shot. That ratio should be a 4-to-1 ratio, and we're at a 1. Then we have the vitality ratio, which is the sodium-potassium ratio, and that's is at 3.3. So we try to look at all these ratios, and what we see when we have this bio-unavailable calcium, it's very predominant in the slow oxidizers. So the slow oxidizers are, the formula for the slow oxidizers, you take the calcium-potassium ratio, subtract it from the sodium-magnesium ratio, and that leaves you at 32. That means this patient is a very, very extreme slow oxidizer, meaning their metabolism is sluggish. So when your metabolism is sluggish, you're not gonna, you're predisposing yourself to fatigue, into weight gain, into being lethargic, the foggy brain. So all these things start to percolate, all the bad stuff starts to percolate, and this is a pattern we don't want to see. So we can correct this pattern with a sound nutritional balancing program, with a detoxification program, so we can start reversing these trends that we're seeing, because these trends are, again, it's premature aging. So this patient, I think she was about 40, in her early 40s. We can start correcting these things, and it doesn't happen overnight. It takes a while to change the biochemistry, but the bottom line is we can change it. We can start influencing it with the science of nutritional balancing and detoxification strategies. So we also see in this pattern, and we're only looking at the 4 minerals on this. There's other minerals that we're not getting into. I'm just sticking to the 4 basics, the 4 main electrolytes: calcium, magnesium, sodium, potassium. So when we see the high sodium, the high calcium and magnesium compared to the sodium potassium ratio, that right there tells you you're a slow oxidizer. That's just from a eyeball perspective. Then you do the formula and you see we're at a very extreme slow oxidation level, meaning slow metabolism. Now, we also see in the young population, we're starting to see the sympathetic dominance. The sympathetic dominance is the mentality of we're always going and we're burning the candle, and it's it's kind of the rat on the wheel, it's the monkey in the cage, and we're just too busy to really relax. We're too busy focusing on the going and not the relaxing, and we're burning out. So when we stay in sympathetic fight or flight, eventually that fight or flight will crash and burn, and we're seeing these patterns of sympathetic domination. So when a hair tissue mineral pattern comes back and the potassium levels are 4 or less, and she's at 3, and you couple that with a sodium-potassium ratio that's above 3, she's at 3.3, that's very indicative of a patient being in that sympathetic burnout pattern, that sympathetic dominance. And again, that sympathetic dominance is what comes up will come down, and when it comes down, then we have the real fatigue. And the difference between adrenal kind of fatigue and adrenal burnout, when we're in adrenal fatigue, usually that sympathetic dominant type of person becomes, they go into adrenal fatigue. Adrenal fatigue can recover with a nice vacation, with extra rest, with taking some days off, and really just kind of chilling and relaxing. Then we can recover, maybe a couple good nights sleep and you recover. When you go into burnout, you don't recover. You're always chronically fatigued, your brain doesn't work, you can't think straight, and you're just walking around basically you're not functioning at a level that you should be functioning at. Libido crashes, energy crashes, the weight gain comes on, all these things that are very common in our culture. So just by looking at this bio-unavailable calcium, the slow oxidation rate, and we can look at the sympathetic dominance, and this pattern is so common. Almost not everyone, about 80%, about 70 to 80% of my patients, I'm seeing this pattern. And in my colleagues that are doing this test report about the same number of statistics, about 70% slow oxidation. We're seeing young 20-year-olds in this sympathetic dominance. We're seeing this massive amounts of calcium, and that bio-unavailable calcium is the death of us all. So we got to pay attention to this, and there's many things we can do. So my goal is to introduce to my patients the art and science of nutritional balancing and detoxification, so we can really change the dynamics of these patterns and swing it to a more favorable pattern. So I hope this talk was helpful. If you have any questions, please give me a call, and I look forward to hearing from you. Thank you for your time.